Welcome back, Lifesavers, to another NCLEX preparation video. My name is Nurse Kelly Tyrrell, and in today's video, we are going to be applying our knowledge of what we have been learning over the last 2 weeks in maternity nursing by going over a few NCLEX practice questions. So let's jump right into some practice questions. Okay, so the first question states, you're assessing the 1-minute APGAR score of a newborn baby. On assessment, you note the following about your newborn patient: flexion of the arms and legs, heart rate of 135, active movement and crying when stimulated, pink body and hands with cyanotic feet, and a weak cry. What is your patient's APGAR score? The options are APGAR score of 8, APGAR score of 6, APGAR score of 9, or APGAR score of 7. If you answered D, that this baby would have an APGAR score of 7, then you are correct. So how did we determine that answer? Well, we have to rewind to a few YouTube videos ago and remember when I reviewed the mnemonic APGAR. So let's break down this question and compare it to the APGAR scoring scale. Okay, so the first assessment given is flexion of the arms and legs. So this baby would score a 1 in the activity category. Next is the heart rate of 135. So according to the APGAR scoring, this baby would score a 2 since the heart rate is over 100 beats per minute. Next is active movement and crying when stimulated. So that means that this baby would score a 2 in the grimace category as well. Next, it says the baby is pink on the body and hands, but the feet are cyanotic. In this appearance category, the baby would actually score a 1. And the last assessment is the baby had a weak cry. This would score the baby a 1 in the respirations category. So if you add all those up, we get a total score of 7, which is a normal score for a 1-minute APGAR. Okay, so let's take a look at a fetal stages of development question. So the question reads, a woman at 35 weeks of gestation has had an amniocentesis. The results revealed that surface actin phospholipids are present in the amniotic fluid. The nurse is aware that this finding indicates option 1, the fetus is at risk for Down syndrome. Option 2, the woman is at risk for developing preterm labor. Option 3, lung maturity. Option 4, meconium is present in the amniotic fluid. So the answer to this question is C. The presence of surface actin or surfactant indicates normal lung maturity in the growing baby. So if you remember from my lecture on fetal staging, I talked about how at 28 weeks of gestation, the baby will start practicing breathing in the womb and will secrete that excess surfactant into the amniotic fluid. This is a very normal and healthy sign of development in the baby. So the presence of surface actin phospholipids is not any indication of Down syndrome or preterm labor, and meconium should never be present in the amniotic fluid because if you remember, meconium is the baby's first bowel movement, which should always happen after the baby is born. All right, so let's move on to the next question. So the question reads, the nurse is caring for a client in labor. Which assessment finding indicates to the nurse that the client is beginning the 2nd stage of labor? The options are, the contractions are regular, the membranes have ruptured, the cervix is completely dilated, the cervix starts to expel clear fluid. So the correct answer for this question is answer C. The cervix is completely dilated. So if you remember from my stages of labor lecture, I talked about the 2nd stage of labor, which starts when cervical dilation reaches 10 centimeters and ends when the baby is delivered. So at this stage, the patient feels an uncontrollable urge to push, and contractions become regular during the active phase in stage 1 of labor, as well as the membrane ruptures. And clear vaginal fluid will start to expel during the preparatory stage, which is actually stage 1 of labor. All right, next question. So the question reads, a nurse is monitoring the amount of lochia drainage in a client who is 2 hours postpartum and notes the client has a saturated perineal pad within the hour. The nurse reports the amount of lochia flow as option 1, scant, 2, light, 3, heavy, or 4, excessive. Okay, so this is also from my Stages of Labor lecture, and the correct answer here is actually C. So the lochia flow would be considered heavy. Lochia that saturates 1 pad every 15 minutes is considered excessive bleeding. 1 pad per hour is considered heavy bleeding. 1 pad every 2 to 3 hours is considered light, and 1 pad greater than 4 hours is considered scant. Okay, let's move on to the next question. The question reads, a client who is 34 weeks pregnant arrives at the ER with severe abdominal pain, uterine tenderness, and an increased uterine tone. The client denies vaginal bleeding. The external fetal monitor shows fetal distress with severe variable D cells. The client most likely is showing which of the following? Options are abruptio placentae, placenta previa, molar pregnancy, or ectopic pregnancy. If you answered A, abruptio placenta, then you are correct. So this information was covered in my maternal complications and treatments video. So with abruption, you want to remember the mnemonic detached. So these patients are going to have a severe pain, tenderness, a hard uterus upon palpation from that concealed bleeding that we had talked about, and fetal distress because the placenta is detaching from the uterus and causing the baby to stop getting those nutrients. And also it causes a backflow of blood through the top part of the uterus and into the fallopian tubes. So with placental abruption, just remember that you may not always see vaginal bleeding because the blood can move backwards through the uterus instead of actually coming out through the cervix and the vaginal cavity. So the other answers aren't correct because placenta previa usually involves painless vaginal bleeding without uterine contractions. A molar pregnancy generally would be detected before 34 weeks gestation, and an ectopic pregnancy, which occurs in the fallopian tubes, would definitely rupture before 34 weeks of gestation. Okay, so now we're going to review our last question, and the question reads, the nurse receives an order to start an infusion for a client who is hemorrhaging due to placenta previa. What supplies will be needed? Option 1, Y tubing, normal saline solution, and a 20 gauge catheter. Option 2, Y tubing, lactated ringer solution, and an 18 gauge catheter. Option 3, Y tubing, normal saline, and an 18 gauge catheter. Or option 4, Y tubing, lactated ringers, and a 20 gauge catheter. So the correct answer for this one is going to be C, Y tubing, normal saline, and an 18 gauge catheter. So if you remember from my last lecture, I talked about patients with placenta previa and placenta abruption, and they are at the highest risk of hemorrhaging. So they're going to be priority patients. Blood transfusions require Y tubing and normal saline solution to mix with the blood product. Lactated ringer solutions are not the preferred solution to mix with any kind of blood product. And an 18 gauge needle is also needed to administer blood because it is a larger bore IV. So the smaller the gauge means the slower the flow rate and the higher the risk of clotting is. So you just want to remember the smaller the number means the larger the catheter. So a 20 gauge cath lumen is not large enough for a blood transfusion. It's an oxymoron. I know the smaller the number, the larger the bore. Whoever invented this sizing on IV gauges should have consulted with Benjamin Franklin because, fun fact, did you know that Benjamin Franklin actually invented the first Foley catheter for his brother who had bladder stones? I know, my mind is blown too. So unlike Frenches on Foleys, where as the Frenches get bigger, the Foley gets bigger, it's the opposite with IV gauges. So as the gauge gets bigger, the catheter actually gets smaller. And that concludes the end of this lesson. I hope that you found this information extremely valuable and it made you just a little more confident as you prepare to take your NCLEX. I just want to thank you so much again, Lifesavers, for tuning in today. My name is Nurse Kelly Tyrrell, and I help nurses feel more confident, increase their test scores, and retain what they don't remember in nursing school. If this video helped you in any way, be sure to give it a thumbs up. Also, don't forget to smash that subscribe button and click that notification bell so you don't miss out on any of my upcoming content and future videos. And why don't you go ahead and do me a favor and drop me a comment below. Just let me know where you're at with your nursing journey. I'd love to say hi and just connect with you. Also, make sure you click that share icon to spread the word and encourage a fellow aspiring nurse. And last but not least, when you are ready to take your NCLEX, be sure to check out my NCLEX and Chill review, where I help eliminate eliminate test anxiety, and review detailed test taking strategies so you can have that unfair advantage to pass your exam on your very next attempt. Not ready to end the study sesh yet? Well, you are in luck, because if you stick around, you can watch more of my videos coming at you in 3, 2, 1. Bye, Lifesavers.